Sure. Thank you for the opportunity to give a talk here. And in recent weeks, I've been thinking about what I wanted to share with you. And I made some slides, and I hope you consider them interesting. And if not, just look at some other sites. But I will try to keep it interesting for you. My name is Peter van den Berg. I was working until recent retirement at the FLS of the Reinier de Graaf Gasthuis Delft. In 2020, I had the opportunity to finalize my PhD on secondary fracture prevention care managed by nurse practitioners. I have no disclosures. I think the content of this talk will be especially what are effective nursing concepts, not especially a nurse intervention, but especially a concept. I've been looking for evidence-based nursing interventions, and I would like to share with you the difference between medical and nurses diagnosis. And of course, I would make a little jump to secondary fracture prevention as a normal part of primary fracture prevention. A nursing diagnosis is, for some of you, perhaps not too familiar, but it's a clinical judgment regarding a human response, and that can be quite something. It can be at an individual level. Nurses can also look at family level, group level, even community levels. A nursing diagnosis should be the basis for an intervention. And of course, you have the outcomes. In the NANDA taxonomy, it's described very extensively, and also the NIC, the interventions, and the NOC, the outcomes, are described by NANDA. So if you want to have a very good insight in what the diagnosis, the interventions, and the outcomes are, just have a look at a very thick book, thick book about the NANDA. The intervention should be a conscious action as part of this care plan based on the diagnosis. Of course, we try to let it have a positive effect, and the outcomes are measured by observation, but also using scales and checklists. The medical diagnosis, you take the relevant medical history. That's different with the nursing diagnosis. I will show that. Also part is the physical examination, not standard available in the nursing diagnosis and process. And of course, that results in planning, treatment, and evaluation. And the nursing process starts with data collection, observation, data collection, subsequently a diagnosis. And this also will result in planning, intervention, and evaluation. But here the treatment is described as intervention. There are three main categories. There are independent interventions, only carried out by a nurse without any input or assistance. That can be the importance of taking medication or other prescribed issues. Another one will be the dependent intervention. And as can be expected, this one requires someone's order, and often that is the physician's order. And that can be the prescription of new medication. And interdependent interventions, and that's what nurses are very used to. They're working as a team, and there will always be someone who prescribes the medication, someone who administers the medication, but also, for instance, the physical therapy as carried out by the physiotherapist or other specialist. Perhaps you do recognize some song text. It's not especially interesting, but it's quite quite an interesting number. If I Should Fall Behind, Bruce Springsteen. So if you want to listen it, Bruce Springsteen, If I Should Fall Behind. Fractures have a significant impact on function and quality of life. We all know, but we often look at the most serious fractures, the vertebral fractures, the hip fractures, but also the more simple fractures do have quite an impact. There is always a related morbidity and mortality, which is also the case in just the normal fractures. And sometimes also the simple fractures result in the necessity of care in nursing homes, and patients can't stay on their own. This demands a multidisciplinary approach. We have heard it before these days. The teamwork is very, very needed in this. But also we heard this week that the prompts, the patient-related outcomes, sometimes are different of the outcomes we think are the best. So involving patients in your decisions is always, I think, needed at this moment. Only looking at your own perspective is not of these times. And I think to provide a good care continuum, nurses and nurse practitioners could have key roles in the gardening of that care continuum. Here you see some nursing diagnoses listed, and in blue the diagnosis, in black the first intervention, which is not especially going in depth, but in this way you should look at the nursing diagnosis and the related interventions. But it also always takes a team to be successful, and acute fracture care requires quite a lot of hospital departments involved. As we all know, the emergency department is one of them, but also the fracture clinic and trauma ward. The recognition of complex needs of older and frail patients should be recognized, and to prevent fragmentation and thereby less effective care is one of the main issues. I will touch the other one later, the application of advanced triage protocols. As nurses aim to deliver the holistic care, coordination seems in this case a nurse intervention, and all the white lines you see in this picture, I think they all can depict a nurse intervention, as nothing happens by itself. There will always be the necessity of someone bringing something in movement. There are important issues, and one of the most important issues is that nurses often don't realize how unique their data are. The importance of their data management is not always seen by the profession, and therefore nursing seems to be almost neglected as a partner in healthcare, at least if we are counting the results. Not as a partner in healthcare, as a worker in healthcare, but it's almost impossible to find the interventions nurses have done. So nurses' interventions also are not coded for reimbursement, and the data nurses could collect can't be retrieved as they are not in the patient management system. There is not the availability of a standardized language, one of the ideas behind the NANDA taxonomy. there is a limited insight in the nursing care interventions and also not in the outcomes. At least they are not in combination with the actions of nurses. And if we would imply, if we would look for the implications of nurses' interventions, I would think that our patient management systems would have a different view. And if you look at this picture, there are three yellow ones pointing at a level of care, and it's not about the costs. I would like to say something to you, but especially about all the places where nurses are involved. Nurses are the most important partner in healthcare, as they have the most often contact with patients. We should not underestimate that. I can't let Florence Nightingale not be mentioned, especially in this city where the Nobel Prize of Peace is given yearly. I think the Crimea War and the activities of Florence Nightingale in that period has been, I think, the basis for modern nursing, also for aspect of hygiene, but especially modern nursing. And she was one who said, well, it is really necessary that we, as a nursing group, are going to write down that what we see and that what we do. Because if we don't, nobody else will do it for us. So look for a bit of paper and a pencil and by all means write down. And I think that's one of the things nurses are not good at. They don't write. Articles are not very present. But after my presentation, happily there is a presentation about a book, a nursing book. So there are improvements. There really are improvements. About the secondary fracture prevention in acute care, I think the best intervention by far is primary prevention, which is always a difficult one. But I think very many nurses working in home care situations are experienced and strong observers, and they do know the differences in patient care between today and how patients were yesterday. And again, a song, you may recognize Bob Dylan. I don't think we have to teach patients in getting young. It's not possible to keep your patients young, but you can prevent them in getting old, and old in a biological way. So in the Netherlands, we started to write a nursing prevention guideline, especially to prevent fractures, to prevent falls in the situation during home care. So before they enter our acute care, we would like to prevent them together. And we hope this guideline, especially for nurses working in home care, would be a great improvement, and we hope this will be launched early 2024, and it's developed with the help of the Dutch National Council. There has been quite a nice article by McDonald, and McDonald has looked at what are effective nurse interventions regarding all interesting points in this phase, and what is especially important that she sent this as a questionnaire to other hospitals, and they could let her know what were her results. That's not what I want to share with you, but the most important thing I found was that she made, as far as I know, as one of the first, the idea of bone health. Secondary fracture prevention was part of the deal. I had promised you to look at simple fractures. So I would like to look with you to patients who can be treated in plaster. Plaster is a disaster in the elderly patient. It's often a disaster in the younger patient, but especially in the elderly patient. And if you look at the picture, the upper picture, you see that this patient is being punished for having her arm broken. There are better solutions than such a plaster, and if you look at the one below, that suggests at least that there are better options. You can always change the plaster of Paris, especially in non-displaced fractures, by other splints which are off-shelf available. But on the other hand, in nurses' trained hands, plaster application is quick and easy to apply. In the community, nurses can look after patients in a POP, and of course, nurses can always monitor how rehabilitation works. They can look at the effects of medication, and especially bone health should have a good place. There are, of course, problems with plaster. The complications are there. They should be monitored as well. There is a new idea going on that to try to limit the waiting time on emergency care departments, to start with what they call nurse-initiated acute care interventions. And these acute care interventions allow nurses to start with pain medication, ordering investigations, and this seems to work, and these nurse protocols reduce the length of the stay without problems with safety and quality. There are 3 nice articles about it. And the outcome was improved pain relief, the symptoms relief decreased, and especially an increased patient satisfaction. Main reason was, of course, optimizing patient flow. I think these integrated interventions may provide support in new models of acute care and especially nurse leadership. Some points about the non-physician health professionals, nurses as well. Bone health should have high priority. It should have the priority already when patients enter the emergency room, and it should contain all these points, of which we all are very well known, I think. But there is a very serious threat, and I need to mention it. Worldwide, there is an enormous shortage of nurses. So we can all say it should be done by a nurse, or it can be done by a nurse, but mind, there is an enormous shortage, which was even exacerbated by the pandemic. And this caused an enormous pressure on the working staff, and even resulted in overworked staff. In the Netherlands, which is only a small country, in 2030, a shortage of about 25 nurses are expected. The unmet needs, I think that very many fracture patients only identify the fall as the reason for fracture. And they need to be educated in that. Patients are often not aware of the relationship between bone quality and the fracture. They often overestimate their physical condition, but they underestimate their subsequent fall risk. Of course, they are unaware of mortality after fracture, but I think most caregivers should be aware of mortality after fracture, also after a simple fracture, what we call simple fractures. Therefore, patients will not attend your initiative without appropriate information, really necessary. I need to summarize and then I will stop. All right? Okay. Well, I could talk for hours, but not in English, of course. Nurse fracture care interventions require well positioning. They must be evidence-based and measurable. They should be part of patient management systems. I think that is very important. But also nurses should take by themselves the lead in coordinating roles. They should make themselves more visible in bone health. And patients are not aware of bone health and fracture risk. So meet patients' unmet needs, empathy, information and education. Thank you for your attention.
Thank you, Peter. We're going to